Hello everybody. Good day to you all. Thanks to the organizing committee for giving me the kind invitation to give you this case presentation, what will hopefully turn out to be for you an interesting acute cardiac care presentation, which I entitled CCU roller coaster. So my name is Hrvoje. I work in the CCU department in the University Hospital Center Zagreb. My predominant field of interest is interventional cardiology, but also acute cardiovascular care. I will talk briefly about a male patient, 63 years old. He's currently hospitalized in our clinic, so this is a very fresh clinical case. The start of this case started maybe 12 or 13 days ago, and he's currently in our CCU. So it's a 63 years old patient without any significant comorbidities, without any relevant medical history, besides being a partial smoker during the last 20 or 30 years. He came to our emergency department due to severe acute onset of chest pain, which was for the first time in his life ever. This was his vital signs, so he had normal blood pressure and normal pulse. He was normally saturated. He had no signs of central or peripheral congestion, and this was his ECG that was done in the emergency department. You can see the ECG that corresponds to the one of the most ominous ECGs that we don't want to see in our patients, that probably has an acute coronary syndrome. So the diffuse ischemia of the left ventricle, probably that has to do something with the left main involvement. He was fastly admitted to the CCU. He was stable, but when he came to the CCU after 10 or 12 minutes, he wasn't stable anymore. His blood pressure was 60/40. He was tachycardic, in sinus tachycardia. He was pale, prostrated, and now he started to have central signs of central congestion, so he had bilateral pulmonary crackles. His arterial blood gas analysis showed lactic acidosis with saturation of oxygen about 82%, and this is his echo. Here you will see a stunned myocardium with EF of about 15%, the poor ejection fraction of the right ventricle. Now we have to decide which inotropic agent you should use. In regards to the patient with acute cardiogenic shock, we tend to go with the inotropic form of the dobutamine. It's the perfect, so-called perfect of the old inotropes. It has a good inotropic agonism while not obtaining any difference in systemic vascular resistance, and by introducing noradrenaline or norepinephrine, you have the increase in vascular resistance. So by administering both the dobutamine and noradrenaline, you can put your patient in a right balance regarding the inotropic effect and then the peripheral vascular resistance. So this is the choice that we will make in this kind of a patient. When regards to the ventilation comes, this patient that is very prone to a fast crash and burn situation is, in my opinion, a good patient for an early intubation, not considering him on any other forms of non-invasive ventilation before. So very early intubation, and then trying to go very rapidly if the clinical scenario suggests weaning from the invasive ventilation. And the mechanical support, which we always take into account fast in our decision-making process in this patient, is going to go somewhere between the ECMO, Impella or IVAC, and this is the thing that I will like to show you, which is why we don't consider these modern techniques regarding Impella and IVAC, which are very modern and very fresh in our opinion, and we tend to go with those options in modern times much often than earlier. But this is a good patient, in my opinion, to go straight forward if he goes into further hemodynamic instability for VA ECMO option. So this patient was put with 2 6 French cannulas for the preparation of the arterial and venous cannulation for ECMO. So these are the right one cannulas that were put in the right groin. Then he was transferred to the cath lab. In the cath lab, he was introduced with the 7 French left common femoral artery sheet that was used to go with the intervention. And then in the start, before the intervention started, we inserted vena arterial cannula for the vena arterial ECMO because he wasn't good. he was on the high levels of the butamine and noradrenaline, and the ECMO circuit was started before the PCI began. So now you will find very fine still images of the coronary videos. Here you, if you can imagine, will see on the left portion of the screen occlusion of the dominant right coronary artery, and on the left screen you will see the CTO of the left main coronary artery. So this is a patient with the CTO of the left main coronary artery with acute coronary syndrome. That is the culprit vessel, is the right coronary artery. In the next step, you will see a very good result, I can assure you, with the placement of one stent in the right coronary artery with a very good TIMI3 flow. And afterwards, you will see the very good intervention with Corsair Pro microcatheter and Gaia second CTO wire that will revascularize the LMCA and the LAD, and one long stent, 40 millimeters, will be placed from the ostium of the left main to the proximal part of the LAD with a very good and perfect angiographic result. This is the ECMO day 1 after the patient is being returned to the CCO. This is the typical chart of the patient during the first day of the ECMO. So here you can see the very positive balance of the fluid. So you see that we in patient we administrated roughly about 6 liters of fluid, and his diuresis was roughly about 2 liters, so everything went into the third place. This is the typical example of the ECMO patient on day 1 when you need to put him in on big fluid volume, and you will obtain the normal intravenous pressures, but in the normal situation you would think that this patient with plus of the volume overload of about 3 liters would have a CVT of about 20 or 25. All the volume goes into third place, and he needs this volume to achieve normal volemic status. In the chart regarding the arterial blood pressure, you will see that he's normotensive on the butamine and noradrenaline, and on the respiratory side, he has VO2 about 35%, and his saturation is 99 or 100%, and his medications are seen over here. So these are no butamine, noradrenaline. He's sedated with midazolam. He has heparin. He has dual antiplatelet therapy, some amiodarone, and some volume repletion therapies. This is his our diuresis, which shows a normal portion of diuresis during the first day. On the echo, you will see the heavily damaged function of the left ventricle, which isn't thinned. There is no signs of scars, and this is a good scenario because he doesn't have any significant mitral regurgitation, and this patient is considered to be a optimal candidate if we need a prolonged mechanical intervention and mechanical and circulatory support to be an Impella plus ECMO case, but this one was very stable. He didn't have any signs of ECMO lung development during the few days after the ECMO was administered, and since his echoes showed a significant improvement and his hemodynamic status began to be better, we started to think of this patient as a good candidate for VA ECMO weaning. Here you can see the typical clearance of creatinine roughly about the first week. So the creatinine levels that were very good. This is the typical situation in a patient with ECMO. So you have a very good kidney function. Here is the hemoglobin and liver function enzymes that show that this patient had a very good perfusion of the all organs in the human body. The plan was after the 4th day we will opt this patient as a good candidate for weaning. So the plan was to go into the cath lab and to put 2 per-close systems plus or minus 1 angioseal for the occlusion of the 16 French ECMO arterial cannula, and to put a Z-stitch on the venous 23 French cannula. After the first per-close, so first per-close was positioned, and we had no bleeding, and so the first operator said, "Oh my God, I'm so good." So only one ProGlide managed to stop the bleeding, and the second one said, "Oh, something is not good." Tried to palpate the artery distally, and we had no pulse. So we had an occlusion of femoral common artery that is not seen here, but I can assure you that here you will see a big thrombus that is going from the start of the iliac external artery all the way through the common femoral artery. And in the second look, and this is the most major part of my presentation, so you will see that the guiding catheter isn't going to go into the right lumen, it's always going into the section part of the artery. Why did this happen? Because the probable, my thought was that when the arterial cannula was placed, it dissected the retrogradely common femoral and iliac artery, and then when you had the retrograde push from the ECMO blood, everything was good. After the arterial cannula was extracted, then the anterograde flow of the blood just pushed the intimal flap in its original place, and you had an occlusion of the femoral common artery. So afterwards, what we did was that we punctured the femoral superficial artery retrogradely. We passed over with the J wire. Afterwards, we put one Bentley graft into the position of the arterial cannula puncture site, and two stents into the artery, external iliac artery on the right side, with very good result and very good flow in the distal parts of the right leg. So after the ECMO was successfully weaned, you can see that he has a diuresis which is roughly in the normal side of his volume intake. His CVT is normal, his blood pressure is normal, he's not anymore on any noradrenaline. He has only a lower dose of the butamin, roughly about 4 to 5 micrograms per kilo per minute. He has now VO2 of about, I think, what does it say, 70–80%, so a larger amount of FeO2 now that we extracted the vena arterial cannula. But now, currently, 2 days ago, he has some pneumonia, but he's on high flow oxygen, and he's doing quite well. This is his daily diuresis, and this is his echo, which shows an ejection fraction about 30–35%, with a good fraction and a good systolic function of the right ventricle. He is currently conscious, fully alert, with normal verbal contact. He has normal bilateral perfusion with normal motoric function of both legs, preferably the right one that we were trying to keep alive. He's currently on FeO2 0.4 on high flow oxygen. He has a good urinary output, and he has a good saturation. He's still on some lower dose of the butamin. So the idea behind this case was to tell you that the Impella, IVAC, which are all modern mechanical circulatory support options, which tend to overflow the LinkedIn and other social networks nowadays, aren't suitable mechanical circulatory support options for all the patients. This is a perfect candidate for the whole respiratory and circulatory support, so that's why you need a VA ECMO on this patient. You will not be able to go good with this patient if you opt only for the Impella or IVAC. Early withdrawal or all escalation of the mechanical circulatory support is of paramount importance. Don't get lazy and be proactive every day, every hour, during not working hours and working hours, and learn to master all the different invasive skills, even the peripheral ones, as they will find to be very helpful to you in your everyday management. Sorry for the videos.